finally, a source of raw, real, and honest information on healthcare issues that matter most. Welcome to BS Free MD. From the latest medical information to how to stay sane as a doctor or a patient, no subject is taboo, no BS is allowed. Now, let's welcome your hosts, Doctors May and Tim Hindmarsh.
Well, this week is very interesting because this is somebody who was kind of May's first.
My first true podcast
was Dr. John Jurica's nonclinical careers that she started to listen to about 2 years ago.
2019.
And kind of connected us into this doctor podcasting world, which is, been super fun and hopefully helpful for all you folks. So we kind of owe a little bit of at least a debt of appreciation to John and the work that he's done. But before we get to John, we have a word from this week's sponsor.
You're you in 30 years.
Whoa.
Some advice. Open a Laurel Road checking account when you refinance your student loans. You could get a rate as low as 1.37% variable APR, plus a cash bonus.
I can do that.
Also, don't date Parker.
Ew, the defense attorney?
Trust me.
Save yourself with Laurel Road. Visit laurelroad.com/saveyourself for more information. Rates depend on your credit profile and include discounts. Terms and conditions apply. Laurel Road is a brand of KeyBank, member FDIC.
All right, this week I am super excited to have a guest here for you guys to listen to talk about physician non-clinical careers. And before we introduce him, I just want to say this was the very first podcast I ever listened to. I didn't even really know what podcasts were. I'd just been discovering them. I was going through a major crisis in my life in 2019. And I wanted to burn down the house, so to speak, in my career, and found John's podcast, Physician Non-Clinical Careers. So before I say anything more, welcome to the show, John. It is so good to have you here.
It's good to be here. Glad to see you both or hear you both, Tim and May. This is going to be fun.
This is going to be fun. Okay, so I don't know if you knew that. That was... I thought maybe I'd mentioned to it in our DPN network before, but yeah, your show is the first one I discovered. Going through a big burnout, moral injury phase for me, and gosh, I think I binged listened to it while I was working in my garden, and I was off work, and I'm like, okay, this is it, man. I'm just powering through these episodes, loving it. So, why don't you tell the audience, first of all, a little bit about your background and then how you got into doing the podcast?
Well, let's see, my background. So I'm a family physician. I was trained all through the University of Illinois, undergrad, graduate, or medical school, residency, and practiced as a primary care doctor with a small practice for a few years. And I got interested in things at the hospital, like, being a physician advisor for UM and going to committee meetings and things like that. I was kind of a joiner. And then I started to find that I was hating medicine. So it's like, oh man, I got to figure out something. And so I started to reduce my patient time and started getting some part-time paid positions at the hospital. And then I talked to the CEO into give me a job as a VPMA, which became Chief Medical Officer. Along the way, I picked up a MPH. I thought that might be helpful for what I was doing. And then I stopped practicing completely when I was full-time CMO. And when I did that, I was pretty busy. And then about 4 years after doing that, I said, well, you know what? I want to start a new business. So I found some partners to do an urgent care center. And I left that, went back into clinical, and found I had a little more time to do stuff. And that's why I became interested in the blog and then started the podcast. After that, the blog has kind of gone by the wayside. And so here I am. My podcast has always been about non-clinical careers. I was really interested in that. And so now I'm helping people learn about non-clinical careers and non-traditional. I like to throw in the locums and the telemedicine and the DPC and things like that.
So you, obviously you'd been into and segueing in your career into non-clinical career type stuff early on. We were joking earlier, just saying how much your career path has mirrored Tim so much, because I think if there was a committee, he had been on it. I mean, from medical executive committee to parent board to UMC and everything. And he's always, he had that interest to do so. I, on the other hand, had no interest in any of that stuff. I just liked the clinical type medicine for so many years. So I guess how would you, what am I trying to say? How would you sort of segue into physician non-clinical careers if it hadn't been that way, like somebody like me for a long time, it reaches a breaking point. And you're like, okay, I'm totally done with clinical medicine, but I don't have any of this in my back pocket. What does one do?
Barista.
That's what I'm thinking.
Barista. Yeah. Well, let's see. It's not something you can jump into, that's for sure. It does require planning, although I have talked to several people, okay, this would be one end of the spectrum, who reached the breaking point. Unfortunately, I kind of had the same feeling, and looking back, I could have planned better myself, but it does require planning. But if you reach the breaking point, sometimes you just say, I'm going to do anything to make a little money and just stop doing this clinical stuff because it's killing me. And, I've talked to a few guests who lucked out. They started networking like a maniac, called every person they ever went to med school residency with, and they happened to get lucky, pick up someone and said, hey, yeah, I work for an insurance company. It's a life insurance company, and we have an opening for a physician. Do you want to? And she literally changed careers in less than a month. She was a cardiologist.
Wow.
Doesn't happen very often. So you need to somehow put the brakes on, try and get a little bit of space in your life to where you can take a breath and not be in such a hurry, and then start to look at, because it is a process. It's a major process. It's a big process. In fact, I wrote an email recently where I said, moving from one clinical position to another is a big thing. It's stressful. Moving from clinical, let's say regular medicine or to academia or vice versa, that's super stressful. Moving from all clinical to all non-clinical is like crazy town. It really can be a huge culture shock. It's extremely stressful. It's up there with, death, marriage, and other transitions. So you need to step back and use the resources you can find. The podcast is a good one for many that have no other resources because it can get you into it right away. But there are a fair number of resources you can look at and take a little bit more of a measured approach.
So why don't you walk us through, I kind of jumped ahead and I was like, yeah, I have no real interest in a lot of this sort of committee type typical stuff. But why don't you walk us through the options out there as far as, getting started. So there's the kind of, I was thinking more typical things like utilization management, things that you can do while you're still in practicing medicine so you get that experience to other avenues. That's kind of where my brain's going.
If I can kind of jump in just for a second, because
please do.
I've done both, and I've done both at the same time. One of the things that is really striking about going to medical school is that I swear the first 2 years is basically just language training. I mean, you're learning, what's proximal, what's distal, what's, all these different, medical terms, which eventually just become, you understand that because we speak that way because it's actually really efficient to communicate medical information to another, clinician. And so the other thing you have to understand, and this is what really blew me away, because I had started doing utilization management and serving on committees fairly early in my career. So as I was learning how to practice medicine, I was learning how, administrations work, how insurance companies work, how governments interface with insurance companies. And what really started to blow my mind is, and I understand why it's that way, but the person that hasn't done that, just goes to work and sees patients, is essentially clueless on the language and the practice of sort of how insurance works, how governments interface with insurance, how administrations work, and that's the thing. Like, I've always talked about how doctors and lawyers speak differently. Doctors speak in possibilities, lawyers speak in possibilities, and doctors are probabilities, because anything's possible in medicine. The person with a sore throat could have tonsillar cancer, but it's probably strep throat, right? So you go with what's the most probable. A lawyer's like, well, is it possible for this to happen? And the answer is, when you talk to a doctor, it's like, well, of course it's possible. And it's the same way when you start talking to insurance companies and you start talking to administrators. They speak in an entirely different language. And so I think it's really important as you bring this up. It's a big transition, and it's a big transition just because you're really smart at medicine doesn't mean you're really smart at everything. And so you really have to kind of walk yourself through, hey, is this a language I want to speak? Is this a vibe I want to be part of? Did I go into medicine because I love the system side of it and all of those things, or did I go just because I want these really amazing relationships with patients? And I think that's because you're going to have crap in any job, and part of switching jobs is deciding that putting up with this crap's better than the crap I was putting up with before.
Yeah, that's true. And if you speak to a coach, a physician coach that coaches other physicians about careers, they spend a lot of time on this. I've interviewed a lot of coaches, and they always focus on stepping back, really, and doing some reflection and an assessment, and really go through a process of, okay, well, what about practice did I like? What about practice do I hate? What do I think I would like? What is my life going to look like in 5 years in the ideal world? And through that, sort of see where you might want to go. But the problem is you don't know what's available. If you're spending a lot of time in the hospital, you probably know what's available in the hospital. So I still think it's best to step back, because maybe it'd be better to do something outside of the hospital. If you're taking care of patients in the hospital and you're treating them with medications, you probably have 10 different ways to get into pharma. If you play your cards right without really doing a whole lot of other things other than spending a few months starting to become an expert in one or two drugs, or somehow participate in a study or this or that. So it's good to get this. And I think the coaches always tell us, kind of back up and kind of get a list. In fact, let me give you just the industries out there. It's a place to start. So you have all the hospital and health system industries. So you have all the things you do there as a medical director, physician advisor, or VPMA, or chief medical officer, or chief medical information officer. And you can do those levels for almost anything. So you can do that in quality. You can do that in CDI, documentation and coding. You can do that in like you did and I did. You can do that in informatics. And then you could do that in almost any service line. I mean, you can become a medical director for ER, medical director for this, that, and the other, if you're a pathologist for lab and so forth. So there's dozens and dozens of jobs in the hospital setting. So we'll put that aside for a second. Then you've got pharma and medical devices. So there's thousands and thousands of jobs in that industry. But most of us don't know how to get into it, so then you're going to have to study how to do that. And that's another, I guess I'd call it a dialect within the lingo you were talking about, Tim, about you got to learn a new lingo. You also have to learn lingo of any individual non-clinical career that you're shooting for.
The only thing I knew about pharma for years, obviously, was back in the day when the drug rep would come by with the samples, sign here. They'll, read you a little bit of a study that's always pre-selected, obviously. And that was that. And of course, I knew that in the academic settings, which, we're rural medicine always, but in the academic world, there's always going to be physicians involved in studies of these medications. But to me, that was always the two options. It was be involved in a pharma study, or, represent the drug, or go be a drug rep. I mean, so there's a whole other pile out there, obviously, right, in pharma.
Yeah, and do you still see reps? Do they ever come around anymore? I don't see them.
No,
it's
never.
Unfortunate, because you don't really want to be a sales rep, but you might want to become a medical science liaison, which is the educational corollary to a sales rep. And the thing is, a sales rep could introduce you to the MSL, who would then give you an idea of how to apply to the company that they're working for, or other companies, or maybe they've worked for other companies. That's like an entry-level job. There's a lot of travel. It's not ideal. And actually, a lot of physicians who don't have residency training at all or aren't licensed can get that MSL job. But if you get further into pharma, you could, even if you aren't from academia, you can get a job related to even clinical development, drug development. And then there's a whole section that's called medical affairs, which is where they take the drug that's already approved and get it out into the world. And let's see. And then there's safety and pharmacovigilance. So pharma has a lot of big areas within it that employ physicians. There's parts that don't, like marketing, but other than the sales rep perhaps. But I don't think too many physicians are sales rep for drug companies. So it's massive.
And to do those, I mean, in your experience and from the people that you've interviewed, I mean, you pretty much need to be in a major city where those companies are located. Is that's not something you can do like remotely, or, you know, if you're living in rural Oregon as we are. I mean, that ability to do that is, I mean, unless you're willing to relocate, correct?
Yes and no. Of course, COVID has put the real extended that, you know, what's possibly home based. Now, a medical science liaison, again, that's a common one that both residency and non-residency trained physicians do. You don't really have to be in a big area because you're going to travel. Just so if you're in a city, it's great because you get to travel around the city and go home at night. If you live in rural, let's say I knew someone who was on the West Coast somewhere, well, her territory for a small drug company was Hawaii, California, and Washington State.
Oh, darn.
I mean, yes and no. It took about 6 months before she got burned out from flying and spending one day in Hawaii and flying back and missing her family. So there's good and bad of all these things. But yeah, there's a lot more that's home-based. So you can be a medical monitor, you know, basically someone who helps monitor the safety and the protocols for drug studies, even if you don't have a lot of background in, you know, academia or in research, and that requires travel. So a lot of times it's a remote job, and then you just interface with the office, you know, online. So it just depends. So yeah, there's a lot more home-based, what we call remote jobs, than you would think.
And then,
I mean, just to change the subject for 1 minute about this, just as an example, as I talked to a woman who was she was working as like a medical director or a CMO for a MAC. I don't know if you remember what a MAC is, but that's what tells hospitals what they can do and not do. It's a Medicare administrative council or something. Anyway, she was completely remote. In fact, it was home-based. She was flexible. She could take care of her kids. And it's like, who on earth would think you could work for a MAC from home? But you just wouldn't expect it.
wow. So, okay, so we've got the sort of hospital-based type stuff, more traditional admin, the pharma end. So what's the next kind of big group that comes to mind of non-clinical? I mean, is it more the non-traditional things like writing, blogs?
Yes, that was actually going to be my next, the next big group, only because there's different kinds of jobs and many different jobs, is medical writing. So you have everything from technical writing, you know, where you're actually working for a pharma company or a CRO, a contract research organization, which is another acronym to know because they have jobs that support pharma, and it's easier to get in with a CRO than it is with a pharma company because the CRO will take temporary, or they'll take contract employees as opposed to the pharma companies. And that's one end of the spectrum. And then on the other end, you know, is journalistic writing where you're writing for a newspaper or a medical journal or something like that, not something that's, you know, research-based, but just journalistic. And then you've got, in between, you've got CME, medical communications. There's a lot of medical writing jobs. Now, a lot of those, if you're freelancing, it requires a lot of discipline, but it's completely home-based, and you can do it while you're traveling, actually. One of my guests on the podcast is a neurologist who actually went 10 years supporting himself as a medical writer. He'd go to conferences, he'd attend 5 or 6 lectures, he'd prepare, I don't know, a dozen articles, and he had relationships with publishers, and he did that for 10 years. He was scuba diving in the Philippines. He was traveling around the country, and then he went back into clinical after 10 years. We do not advise that, but he actually did that. And he's still practicing at the University of Tennessee right now.
Wow.
Yeah, that one.
I had about a year off with kids and stuff happening, and I thought I was like the biggest idiot in the world because things change so quick, and I'm in primary care, right? And I literally was watching ER back in the day on TV, and I'd say to Tim, "You can do that now? You can like put the TPA right in there?" And
you mean they take them straight to the cath lab?
Yeah, exactly.
Yeah, right. No, that was true. That's true. I would say a year or two is the most. And for some specialties, unless you've seen patients actively manage them within a year, you can't get insured. Like OB-GYNs, it's almost impossible after a year. You have to do something once a month or a week a month or something to maintain it. So we don't recommend that. But his story is pretty remarkable. That was a few years back.
Boy, that's... Yeah, my problem when I hear support yourself, that means that is something different to every single person in the entire world.
That's true. But he basically made this equivalent salary to, I would say, a family physician, based on that. Probably less than a neurologist might make doing procedures. But, yeah, he was happy. And but he went back. He missed the clinical. But the thing about him was because he was writing about current studies and meetings and things, he was up to date on everything. He just hadn't physically seen a patient directly in 10 years.
No, but can you imagine, not to get down a bunny trail, can you imagine if the year you took off was the last year and you were working in an ER, a hospital setting, primary, like to go back? Like when I think of how much I know about COVID.
Oh, no kidding.
Like and how much reading I've done and how many patients I've treated. And, like it's like you would be completely worthless.
Unless you're one of the people that just says, shoo, COVID, you people, shoo.
Yeah, that's what we do at my clinic. That's what we do at my clinic now. And that's one of the reasons my last shift was a week or two ago, because I really don't want to learn how to treat COVID patients properly. In the sense, I want them to be treated properly. I don't want to have to restructure the way we do things in a clinic. Let someone else do that. It's a lot, definitely. Things change very quickly.
Yeah, no kidding. So I know that there are lots of other kind of little esoteric non-clinical things from
pole dancing.
Stop it. Yeah.
It's not clinical.
It's truly
That's
not.
True.
That's truly not. Maybe that's more the line of thinking I'm going down here, not pole dancing. But,
there you go.
Okay. But to use your degree, I guess things like, so there's IME exams. We've actually interviewed ourselves a really interesting guest who maybe you should have him on your show. Give you his info, but he does legal consulting, and he's not an attorney, but he's doesn't do the typical IME either. He's actually the consultant for the attorney, which has been really kind of interesting.
Yeah, so
career path that he created.
He's been on a few of the other former DPN podcasts, but it's fascinating because like how he structured it, and he really niched out and it was brilliant, which was primarily accidents like MVAs and workers' comp, where the attorneys really need a sense of what's going on with the case, and so they need a medical expert. But you're not being a medical expert. Like you're not being paid to be a medical expert. You're just saying, hey, this is medically, I'm answering your medical questions. Here you go. You do whatever. If you want to get experts, I'll help you get experts. And so it's really as a medical consultant. And I found that, I was like, man, that's something I could really get into because it's super diverse, like every kind of medicine. Right. And you find the studies and you quote them and you do a little write-up and you give it to the attorney and away you go.
Mm-hmm. Mm-hmm.
I think consulting is a nice big bucket for a lot of different things. So, like, there's a lot of physicians actually who part-time are medical experts, expert witnesses. That's kind of a form of consulting right there, but unlike what you just described. But there's lots of things that physicians consult about, either part-time, and it gives them that chance that you talked about to do something part-time and kind of grow into it. And it could be running your practice, it can be, whatever, CDI as a consultant. But then you can also work for a healthcare consulting firm, most of which are international. The big ones, the big U.S. ones are actually international, but they all have healthcare, components to them. And there's just a lot of different jobs. It's some kind of revenue cycle thing or quality thing. Every time there's a new thing that has to be learned by a hospital or a physician group, there's a consultant that teaches you how to do it. And most of the time there's a physician consultant in that team. Now they travel a lot, and it's maybe not the best lifestyle if you're trying to get away from clinical because of the lifestyle issues. But it's fun. The people I've talked to, they really enjoy it. It's challenging. They have great teams, and I've interviewed several that really have done it for many years. That's not something you can go back to clinical either once you've been out. In fact, they also like to sometimes actually recruit physicians who haven't been in practice because we tend to get some bad habits in their minds. We get cocky and we think we know everything.
No.
So that's how that works.
So let's talk a little bit about the other big thing that, or not path, but career that we see happening, and honestly we truly secretly have mocked it, which is physician coaching, because we used to say is where physicians go to die when they're done doing clinical medicine to coach other physicians how to get out of clinical medicine, to coach other physicians to get out of clinical medicine. And
It's like a gender studies degree.
stop.
Maybe Amway, I don't know.
But in all seriousness, I mean, there's times when I'm like, I think I really need help. I need a coach. It's like a medical shrink in some ways for careers because I'm really lost. And you're right. There's a lot of things out there that you might not know about, trying to figure out really, what can you put up with, what can you not, what are your passions. And you think this might be a good career path, but it might not because of, you kind of come up with a list of goals and things. So why don't you tell us a little bit about your sort of experience with the coaching, people that coach, how that goes and what you think.
So when I started, which wasn't that long ago, about 5 years ago, there was a handful of coaches that I could even name. There just weren't that many. It's become a very big thing. And I'll tell you why, in a sense. Most of them, by the way, are well-trained. I mean, they do get additional certifications. They have a lot of hands-on training under supervision, how to coach. And I mean, it's not rocket science. You can learn to coach pretty easily. But I think it's nice to have that formal training, and most of them do. There's just a whole subset of us who, when we get to that point where, okay, medicine is my life, medicine is what I've always wanted to do, and I have a mental block. I mean, I cannot think about doing anything other than medicine, but I hate it and I can't do it anymore. And so they spend a lot of time really on the mindset issues, not saying here's where you should look or here's where you should apply. It's more about, okay, let's step back again and talk about what would your ideal life be like? What is attractive to you? Some of them use, personality testing and enneagrams and everything you can think of to try and align them with what might work for them. But I do, the coaches that I've talked to, I have a lot of respect for. It's not easy work, actually. It's not high-paid work. So, I mean, they got to coach, people 6, 7, 8 hours a day to make anywhere near what they made as a physician. But what I always say, in retrospect, is that being a physician coach has all the upsides and the positive aspects of being a physician with none of the bullshit. You can't get sued. It's almost impossible. You don't have to be on call. You work when you want to work. There are ways to leverage it. You can do group coaching and mastermind groups and other things. So it turns out that one of the reasons there's so many physician coaches is it's just an attractive thing to do because you get to help people and be like a physician without having all the crap that normally goes with it.
I'm really curious if there's a study or anybody has any idea about how many people that leave medicine, go through coaching, become coaches. I mean, it just right now it seems like the new shishi thing, almost like selling Amway, or you know what I mean. I think it has its place, but it's like you're right. All of a sudden, it's just like multiplying like crazy.
Well, part of it is one way to answer your question is of the people that end up being coaches, probably 100% of them have been coached because you really shouldn't become a coach until you've had a coach. Mm-hmm. Now, I mean, I suppose I could go into coaching, for example, because when I was at the hospital working as CMO, we had a coach. We had the CEO had a coach. The entire senior team had a coach. The coach would work with us in groups. So it's seen, put aside like the therapy piece of it. I mean, because being a coach is a lot like doing therapy, only you're not really sick and it's not,
well,
clinical.
We hope not.
No, but I mean, a lot of this, the way they do it is very similar, right? They use the same kind of techniques. But in business, most large organizations use coaches all the time. So in that sense, I think that's one of the reasons it's having somewhat of a growth now, because physicians are recognizing that whatever they want to do with their non-clinical career or other aspects like profession, speaking, whatever they're doing, a coach can accelerate that. And then it just becomes a matter, is it worth the cost at the end of the day? I mean, you might get there anyway, but at least the people I've heard that have been coached have said they had breakthroughs and they just moved quickly along much more than they would have if they weren't being coached. In fact, I've actually employed 2 business coaches in the last 2 years just because I wanted to learn something and move forward on something, whatever it might be. And I thought, well, it's worth the money to get that expertise.
Really? I think that you'd be an excellent business or an excellent coach for physicians, like helping figure out the non-clinical careers part, just because of all your experiences as well as, the people you've interviewed, and you kind of have a feel, I think, for what to get, how to get into various things. I don't know. That's just my bias.
Yeah, I guess the question I always have is, it's, not all coaches are created the same, and so, like you find a great coach, it's absolutely going to be worth it if in whatever area. But, again, the
I think
only person that Tony Robbins made money for was himself.
Well,
you bring up a good point, and you have to try and avoid that. And the way you do that, number one, is try to at least get references from someone you know and trust. And if they tell you, boy, this is the best thing since sliced bread, it's probably going to work out. The other thing is, you interview 3 or 4 coaches, you get that 20, 30 minutes, and you go ahead and start with one of them. And after a few sessions, if it's not ringing true, then you just say, well, I think I'm going to stop and maybe move to somebody else. So, yeah, it's not 100%.
Right. So what are the biggest sort of barriers to, switching to non-clinical career? Like, I mean, you mentioned, obviously, it's going to take some time. Usually you can't just pull the plug and quit your, you don't want to just like, I quit, here's my 3 months notice, I'm switching, but you have no clue unless you're like me and you can rely on your husband to take care of you.
Do the heavy lifting.
Exactly. And I'm like, that's it. Financially, you can just work. I'm out. But so what would your recommendations be, like things to how to plan, the big, like Katrina Ubel says, preparing to quit and how to transition and all that?
Just do what Katrina did.
There you go.
Just follow her lead. Well, first of all, let's call Dave Ramsey. You got to have that money. You got to have some money put aside, and just so you can live. Don't bail without a plan.
Right.
And I don't know if you haven't paid your student loans off. I don't know if that should be a barrier. If you're really unhappy, you probably should do something. But, the way I look at it is find resources and just start to learn, start to educate yourself. Just like the first time you started thinking, well, I need to learn about investing, or I need to learn about buying a house, or I need to learn about whatever. It's just a thing that you need to learn about. So there are books out there. There are books written on non-clinical careers. And I can even list a few if you'd like, but they're pretty helpful.
Do you have any favorites as far as the non-clinical career book?
Yeah, this one, Non-Clinical Careers for Physicians. Actually, it's 50 Non-Clinical Careers for Physicians by Sylvie Stacy.
Look at
backwards? That. It's backwards to me.
And you had a list, too, at one point, that was linked to your website? Yes,
I think one of my podcasts, I list resources. There's a podcast I did that were like the low cost and free resources, and it was books. And there's like 4 or 5 halfway decent books. They only get so far, though, in what you need to know. Then there's Facebook groups. So, I don't know, maybe you've seen the Physician Non-Clinical Career Hunters Facebook group.
Yes.
That's by Laura McCain. I was an admin for that for about 5 years. And it has 18,000 members. So you can just go in there and ask questions. There's a group called Alternative Careers for Doctors. I think that one's international, 27,000 members. Remote Careers for Physicians, physician side gigs, Nisha Mehta, I don't know if you know her. Mm-hmm. Yep, that's only has 84,000 people. So, I mean, there's massive numbers, there's massive interest, and there are some good things in Facebook. I mean, other than that, I don't like Facebook in general, but for those groups, it's pretty good. There is not really the equivalent on LinkedIn. I mean, there are groups, but there's not that much engagement there. And then there's the podcasts like this. There's specialty societies. Once you narrow it down, there's specialty societies for almost every type of non-clinical career you could go into, like in pharma or what have you. And some people have courses, and then the coaching is the other one to consider. So those are the resources, and I'd start to just study and think and reflect, and then network and just talk to actually people you already know from med school and residency, because you'll find if you talk to those people, a good third of them will already be out of medicine.
Wow.
Oddly enough.
That's crazy.
Yeah, it's the interesting part, though, I think, and you nailed it, which was the Dave Ramsey part, which is don't spend any money, you're not going to have any fun, and then you're going to retire and die. But but you'll be wealthy, and your children will get money they never earned, which is is the planning, because, May and I had this massive shift in career for a whole bunch of reasons. It really needed to happen. It's worked out to be the best thing that's happened in our careers, for sure the best thing that happened in the second half of our careers. But it was basically like having someone die or getting a divorce. And it's really easy in those crisis times to make incredibly bad choices. Hey,
it's the rebound job, like the rebound relationship. I mean, we sort of done that.
My wife left me 6 months ago. I went on a cruise, and hey, I've known her for 3 weeks. What could possibly go wrong? So, and so I think the plan, and even if you love your job, I think one of the fundamental pillars is it starts with the financial plan, so that when things change, maybe 10 years into your career, maybe 20 years into your career, and you want to have a 35 or 40-year working life, there's going to be a point where, you're going to need to transition. Well, if you don't have, 3, 4, 6 months saved up, you're not doing anything. I mean, you have golden handcuffs on. And, we've learned that.
Well, I think that would be like really good advice, and I'm sure John would echo that, is like to start earlier in your career, trying these things out, committees getting involved.
Exactly. You read my mind, because I had so many avocations that could permanently disable me, motorcycles and skydiving and all this stuff that I literally started to, this is no joke. I literally started saying yes to non-clinical jobs in our health system because I was like, I want to have a place to land if I end up in a wheelchair. Like, what medical job can I do in a wheelchair? Well, I could do utilization management. I could be a medical director. There's all these other things I could do. And so I at least wanted to have, arrows in the quiver, so to speak, that if things changed in life, you move, whatever, you can still do something other than, because that's the handicapping in medicine is you're so narrowly trained that unless you start kind of retraining yourself as you practice, it's very difficult to just go, okay, now I'm going to open a trailer park. Well, you don't know anything about opening a trailer park.
Well, that is true. And I agree with you what you're saying, but at the same time, I want to make sure that the listeners understand that they know a lot about a lot of things more than they really think they do. Like, I've had many people say, "Well, I don't know where to start," and I don't think all I know is medicine. It's like, well, all you know is medicine. It's like, what's a corollary of that? Well, it's like knowing 10 different things. Knowing medicine is anatomy, physiology, statistics, you name it. I oftentimes will bring up this story about, if you were stranded on a desert island, you had like 10 different people that you could be stranded with, and school teacher, policeman, a plumber, whatever, an engineer, and a physician. My first 2 picks are the engineer and the physician.
Yeah, for sure.
Yes, absolutely.
So, there's so many things.
Then the botanist.
yeah. But, even physicians know a little bit of botany, We're always interested in science. So physicians have a lot of skills, and they sell themselves short. Now, what I talk about is always, we're talking about things that relate to medicine. I'm not talking about opening a hot dog stand. But there's so much that we know about medicine and about the healthcare system. If you don't know the healthcare system, there's a lot of people that try to create things, different tools and that. If they don't know the system, they can't. It makes no sense. But you go sit on that board and tell them, well, this is really how medicine works. So there's a lot of things you do have. And the myth, that's kind of one of the myths. It's not easy, but the second myth that I come across a lot is that, I can't really make as much as I could as a physician. Most of the physicians I know that have like really, good jobs, non-clinical, make more than they made, particularly if you look at it on an hourly basis. They're not working 70 hours to make $300,000. They're working 40 hours and they move up in pharma, in the insurance companies, in the hospital settings, CMO and system CMO and COO. And these people are making $1 million a year. I wouldn't bank on that, but non-clinical jobs, some of them pay a lot.
Well, and I think, you nailed it on the one part, which is we need doctors doing non-clinical jobs, especially in the administrative world, because if we're not doing them, somebody else is doing them. And it is it's been one of my biggest frustrations in the administrative system of, whether it's even an insurance company, hospital systems, et cetera, which is, okay, so you have a whatever degree, You've never been to medical school. You've never seen a patient. You've never stayed up all night in residency. You've never peed your pants because you were alone in a rural hospital and it was you trying to make sure that if the next car wreck came in that and then you're going to tell me how I'm supposed to see patients or whatever. And, you go to shake hands with them and their hands are so soft because all they've done is push paper their life. I find that so personally offensive. Whereas I've had physician leaders and administrators, and it's a completely different environment. You sit down, you go, hey, look, they're like, this is what we need from you, and I get it. I get the frustration, and this is how we're going to get through this frustration together, rather than, if you want to get rid of top-down medicine, then some doctors need to move to the top of medicine.
Yeah.
No, that's absolutely right.
Right,
It's
right.
100% right. It's something that the American Association for Physician Leadership stands behind and supports and tries to train physicians to be prepared for that. It's a pet peeve of mine as well. There should be more physician leaders at all levels, and there should be more physicians running hospitals. And in fact, if you look at the U.S. News and World Report, I guess, I don't know, is that the name of the magazine? Anyway, they do an annual review of the highest quality organizations, systems, healthcare systems in the U.S., and there's usually 15. Usually 9 or 10 are run by physicians. The Cleveland Clinics, the Mayos, the, Dartmouth, whatever. The only one that really understands patients more than a patient is a physician, in my opinion. The really nitty-gritty of taking care of a patient.
Right, but
Yeah.
look at how
Yeah,
Mayo,
or a nurse.
Yeah, no, I've had some amazing
Yeah.
executives that were nurses. There's
Yes,
no question. I mean,
exactly.
especially ICU nurses. I mean, they're amazing. But I mean, you look at Mayo and Cleveland Clinic. How did it start? I mean, it started with doctors, and then they built a business and they built a system, and they and how Mayo does stuff and how Mayo pays their physicians is wildly different than how other health systems do. And I think that's really cool. And the doctors agree. It's like, hey, if we're going to build this system, we're going to, be mostly salaried and so forth. And you have other places where, it's a fee-for-service festival and see as many people and bill as much as you can,
Okay.
And so, which is, if you're a business person going into medicine and you rise through the ranks of administration, why would you be a patient advocate? Like, honestly, just rationally, you get promoted for making more money for your company. Whereas when you're
absolutely.
a physician, there's always that little angel on your shoulder going, no, you did this for more than money,
Yeah.
Well, I worked for a hospital. It was a community hospital. And, the two strongest personalities in that hospital were the CEO and the CFO. They weren't clinicians of any sort. And there was a point where our hospital had something like 430 days of cash on hand. That's like the top 1.001% liquidity for a hospital to have, and they wouldn't open or expand their diabetes center. And that was one of the reasons I left. It's like, number one, many hospitals are nonprofits. This was a nonprofit. I mean, obviously they generate income and they have money, but to me, we need more physicians making those decisions and weighing the quality and the access and the safety along with the financial.
No, that's a mind blower. That's like 14 or 15 months of cash on hand. And as I recall, you can correct me if I'm wrong, 6 months cash on hand is basically, your bond rating is essentially maxed out at that point. Anything
right,
more
it's
than
like
that,
130,
no one really
140 days or something, and you're gold, because half the hospitals in Illinois are losing money and going bankrupt. But yeah, so to have that and yet not open some new service line is just ridiculous.
Wow. So, a couple other quick things that came to mind. What's the not craziest, but most unique, or something that stands out in your brain as one of the most kind of more interesting non-clinical careers of people that you've interviewed?
Well, let's see. There are ones that I really like. Yeah, if I could go back and do it, I would be a medical expert. For the court. I just. Because to me, you can make 3 times your hourly salary, and you can balance it and do clinical as well. I talked to someone for another one. She became a patient navigator, And I don't think she makes a lot of money, but she would go in with the patients and their families with really complicated decisions that they had to make, concerning the treatment of some advanced cancer or something. And she would just sit and she would reframe everything and explain it to the family so they can make an informed decision. And she really liked doing that. If she can make it to where it's, reasonable financially, it would be fantastic. I don't know. I've seen people that have gone like they're full-time orthopedics and they're like working for a venture capital firm, recruiting other physicians to invest in some kind of fund or something. That's kind of interesting. I don't know how the orthopedist he's still working full-time and he's a partner in that group, which blows my mind. Those are the ones that stand out. I mean, most of them are sort of mundane, but there's something for everybody out there.
I was hoping I could be like, what's his name? The comedian that's on The Masked Singer, my guy.
Yeah.
Ken.
The actor.
Get a job as an actor because I play one on TV instead of just in real life.
I was thinking of becoming a pole dancing astronaut.
Yeah.
Yeah, if you actually go
physically.
back. No,
Yeah.
we could be. Go back and listen. If he's listened to our April 1st episode of this year.
Oh, yeah. Mm-hmm. I was going to
Then we tried
that.
to venture into space, but it didn't quite work out.
And I actually physically look better in weightlessness.
Imagine
Well,
that.
I think that one kind of blew the BS-free part of your title.
Yes.
So we'll not say more except to go back and listen to all of April's episodes.
There you go. Exactly. Why don't you, I think it's a good segue into letting us know sort of what you're doing now, because you have a little new project that you've been working on called New Script, right? Tell us about that.
Right. So, I'm doing this podcast and I send out an email every day and I actually have an academy, but that wasn't enough. I partnered with someone called somebody called Tom Davis, named Tom, Dr. Tom Davis, and we've been thinking about doing something for several years. And so about a year ago, we started working on a new app. It's actually an app, but it's a community. It is a place where you can talk to experts, you can commiserate with each other, and learn from one another. Plus, we have mentors in there. And the thing is, it's private. It's really uncensored, basically. I mean, we have some guidelines for what you can say, but there's no. It's not like Facebook or something. There's no ads in it. And right now, I think it's just converting from free to, I think, a $5 a month fee to join. And there's about 200 or 300 in there right now. By the time this is posted, I don't know how many will be in there because we just launched this a week ago. And the thing that's different, too, for this is it includes other clinicians. So right now, 95% of the people in there are doctors, but it's going to be for also PAs, NPs, and anyone who has been kind of looking to get out of clinical medicine or clinical care professionally because of just everything that's been going on.
So this is a perfect place for people to go. They're thinking of getting out of clinical medicine to connect with others and sort of have mentorship or ideas tossed around on things out there, etc. I love it.
So kind of, if I'm hearing this right, kind of like a Facebook group for non-clinical careers, but without ads and without censorship.
Right. Although it's like a membership too, because it actually has courses already posted in it. It has live stream events. There'll be one every Wednesday that I'm doing, and then Tom's doing one once or twice a week. And then when the other mentors come in, there will be some like affiliate programs where you can come in, and if you want to learn how to use LinkedIn or something like that, you have a course in there that you might have to pay some for.
I love it. So that's New Script, correct?
New Script.
And just find it on the app
So for the
site?
price of a Starbucks, you
It's
can
it,
launch
Actually,
your new
less than a
That's
Starbucks.
right.
Have you been to Starbucks
Well,
lately?
yeah, you can launch your new career. And maybe get on Bezos's massive phallic rocket ship. That might be over-promising.
Oh my goodness. Okay, I'm super
If you're
excited.
on an iPhone, you can just look it up in the
Right.
store. But you can go to newscript.app and there's like a little landing page that you could also click and join that way.
Well, I'm in because we are
Yeah, get in
definitely
today.
in a transition phase. As you know, Tim is still he's finding his new gumption and his life again in the new clinic we're at, because he has control.
Well,
But
it is really interesting.
but I'm like, I'm out. I'm pulling the plug.
I don't know if you listened to our last podcast when I described the dog poo tennis court.
Oh, the what?
The dog poo tennis court. How?
Yes, I did. Yes.
Right. And so
that was a good, what was it, a metaphor or
Yes.
an analogy, whatever?
Yeah.
You know, and so the thing is that
Well, he's got a new tennis court. I just don't like tennis.
right.
And
well,
that's what
I don't like tennis either necessarily. I'm terrible at it. But to me, there's just nothing more descriptive than every time you hit the ball, it's like all like mushed with
exploding
fresh
with-
Labrador.
Yeah.
But you know, it's you know, that's the thing is that, you know, we're trained so heavily. We work so hard. We care so much. I mean, there's nothing more frustrating than a block. Like what makes frustration? A blocked goal. And when your goal is to help people, and you really are passionate, you're so passionate, you sacrificed your entire young adulthood. You went hundreds of thousands of dollars in debt. You did all of these things, and then some guy with a tenth of your training is getting in the way of what you're doing. I mean, that is so. There's only so many options. Like, you can leave the system, you can unionize, like we talked about, you know, last week. You can, you know, you can start your own practice, which has its own issues, or you can get a non-clinical career. That's it. You know, and so I'd really encourage people to kind of take their power back. That's what a lot of this is that, you know, you don't have to just sit there and take it. There's other stuff that you can do.
I love it.
Absolutely. I mean, you haven't worked all this time, put all this effort in, as you mentioned, all that goes into it. To be unhappy, you should be happy in your job. You should actually open your eyes in the morning and go, oh, it's going to be a cool day. I'm going to get to do something fun. That's the way I look at it.
Love it. Any last words for us while we still have you here?
Yeah, go to New Script, look that up. No, the last word I would say is that, and we didn't talk about this, but there are many non-clinical careers where you can get that fulfillment, you can be happy, and you can actually help more patients doing that non-clinical career than you can individually taking care of a runny nose or what do you call it, the walking well.
Yeah.
You know, I did that for years.
Yes.
And it's a lot more rewarding doing something non-clinical where you're actually impacting hundreds or thousands of patients.
Good point. Love it.
Excellent.
Well, I'm going to encourage the audience to obviously check out your podcasts because it's awesome, as well as check out New Script.
Which I just downloaded whilst we were talking.
Awesome. I'm going to link that in the show notes, and also how to find you on the Facebook group as well, correct?
Yes.
Yes. All right. Thanks again for being here. It's been wonderful. And like I said, it's kind of fun having the very first, your very first podcast.
Okay, I'm reserving comment of what I normally would say because I actually have a filter. It just has really big holes in it, but
pores. Yeah,
Anyway.
It's very porous. But yeah, no. Again,
Thanks for putting up with us, being on the show. It's been really helpful, and it's exciting to have the new app that everyone can check out, and we'll link everything in the show notes. And
it's been my pleasure. I'm happy to be here.
Well, that, I mean, was great. Super informative. I just love sort of it's so easy in medicine because we're trained in such a narrow scope. We're not, if you go to business school, you can run Apple or you can run Pepsi, right? I mean, the same guy did that. Mm-hmm. And so you kind of get used to it. I
always said we were highly trained technicians or monkeys.
Right. And it's good to break out of that and to realize, no. And he says it himself. Like, we brought that up and he says it himself. It's like, no, you got way more on the ball than you think you do. And I wonder sometimes if, the way especially corporate medicine works is it really does, like, the goal of corporate medicine is to keep you in the cubicle seeing as many patients as possible. Mm-hmm. And so, that freedom to break out and say, hey, look, you have an advanced degree, you're obviously pretty intelligent, there's lots of cool stuff that you can do out there.
So using medicine as well, doing something else. And what's fun about his podcast, that if you haven't listened to it, is there's so many things that I'd never thought about, from doing voiceover work, which had me all excited, reading the script for education materials. Someone's got to read that stuff, all those little things we watch, to just writing books, how to publish, to the more typical type of things. So his show's super fun because there's always some great guests on there with awesome tips, even simple things like how to write your resume or your biography to get it out there and get jobs in all these other careers. So I really encourage everybody to take a listen. Obviously, if you're not in the clinical world and you're just here for fun, it might not be your thing. But
because I thought really I was down to two options, which was seeing patients and obviously my second passion of pole dancing.
Mm-hmm. Yeah, back to that one. I think we struck that.
Yeah, we're gonna be
struck that career choice off the list.
Yeah, that ship has sailed a long time ago. So.
All right. Well, we will see you next week with another fun episode coming up to Christmas. So see you next time. It's no secret that medicine is a bit uptight. That's why Tim and I created BS Free MD to mix things up a little and have fun in the process. Besides, we are having these exact same discussions all the time, so we thought we might as well invite everyone to the party. If you really like us, you can get plenty more and maybe see one of Tim's cool tattoos on our Instagram or Facebook pages at BS Free MD. See you next time.
While we try to keep BS Free MD as raw and real as possible, we can't be held responsible for any medical decisions or discussions had as a result of what you've heard on the show. We know, bummer. But the truth is, we really do care about your questions. So feel free to reach out to us by email at doc@bsfreemd.com.